So we'll now move into part 2 of this first week's lecture, and we'll concentrate on some of the aspects of image acquisition for X-rays. Please take time to access the link that's highlighted on this slide, which gives some good detail in terms of the varying positioning for views and projections of the foot and ankle. So it's important that you have a basic understanding of how X-rays work, and please take time to access this link that's on this slide to have some wider reading on this topic area. So to create a radiograph or X-ray, a patient is positioned so that the part of the body being imaged is located between an X-ray source, which you can see as this white camera type thing in the image, and an X-ray detector, which will be the imaging film. When the machine is turned on, X-rays travel through the body and are absorbed in different amounts by the different tissues, depending on the radiological density of the tissues that they pass through. The radiological density is determined both by the density and the atomic number of the materials being imaged. For example, structures such as bone contain calcium. This has a higher atomic number than most tissues. Because of this property, the bones will readily absorb X-rays and thus produce a very high contrast on the X-ray detector. As a result, bony structures will appear whiter than other tissues against the black background of the radiograph. Conversely, X-rays travel more easily through less radiologically dense tissues such as fat and muscle, as well as through air-filled cavities such as the lungs. These structures are displayed in shades of grey on the radiograph. So how will tissues appear on X-ray? Well, in terms of an X-ray, there is a limited expression of X-ray densities. There are only 5, going from air-filled structures such as the lungs, which will appear black, and the highest contrast structures would be metal. And you can see that we have varying expression of radiological densities from air going through to fat, soft tissues, bone, and metal being expressed most brightly on the X-ray. When we're considering X-rays, we also need to appreciate that how the tissues will appear on X-ray in some way will be dependent on the distance of the structure relative to the source. As you can see in this image, the distance from the source and the nature of the projection, so the direction of the beam, whether it be from the front or the back, can influence the apparent size of internal structures. In this example, we can see with a reduced source to detect a distance in the middle, this enlarges the appearance of the heart. If the X-ray is taken from the back instead of the front, the heart will appear smaller. We now need to consider X-ray position and projection. So when we're making an X-ray referral, it's important that we consider the appropriate positioning of the foot and the projection that we request to ensure that we get good visualization of the structures that we're interested in. We need to be aware of some of the aspects previously discussed in terms of avoiding artifacts, so i.e. unnecessary elongation of tissues, and we need to ensure that the projection that we request is appropriate and important for the potential diagnosis. In order to ensure that we make the appropriate referral, we have to ensure that we have a good working knowledge of our anatomy and also consider the 3D structure of the foot and consider how this may appear when it's represented and superimposed as a 2D representation. So I would encourage in the practicals that you spend enough time looking at the architecture of the foot and considering how structures would be superimposed on each other with the differing projections and views. Now, when we are referring people for x-rays or looking at x-rays that have previously been taken, we will need to consider how the x-rays have been taken and what the x-ray will allow us to visualise in terms of the view that this gives. When we talk about projection versus view, this can be a really confusing area. When we consider an x-ray, we need to think firstly about how the body has been positioned. We need to think about the projection of the x-ray beam and where the image receptor, i.e. the x-ray film, will be positioned relative to the structure, and consider how this view will appear. In terms of body positioning for the foot and ankle, this could be weight bearing or non-weight bearing, or we could alter the position of the joint that we are interested in. For example, we could position the ankle in a plantar flex position in order to expose more of the body of the talus if we suspected a talar dome lesion, for example. A projection refers to the way that the X-ray beam passes through the body. It could be anterior-posterior, going from the front to the back, posterior-anterior, going from the back to the front, or medial to lateral, or lateral to medial, going from one side to the other. In the foot, for example, the anterior-posterior projection will pass from the top or anterior surface of the foot and will exit from the bottom, the plantar aspect. This means our X-ray source would be above the foot and the imaging receptor, so the radiographic film, would be placed underneath the foot. The X-ray beam would first hit the top, the dorsum of the foot, and would exit from the plantar surface. The anterior-posterior projection would give us a dorsal plantar view. So we need to consider what structures we want to visualise and what would be the best way of achieving that view of the specific structure with the common projections that would be used. In this table here you can see the common plain film projections for the foot and ankle. Please take time to look at the links and do some wider reading in this area to further your understanding. There will often be variation in how these projections are achieved dependent on which institutions. A general principle is that you would need a minimum of 2 views at right angles to each other to obtain appropriate visualization, specifically when a fracture or dislocation is suspected. These injuries are particularly notorious for being very subtle or even invisible in just one projection, when they can be quite glaringly obvious in another view. To illustrate the point that I've just made, we can see why 2 views would be necessary. So here we can see an AP view of the ankle. So whilst X-rays can give a great deal of detail of the bones, we've got to remember that we are getting a 2D representation, and we need to look at the 3D structure. If we look at this X-ray, we will note the alignment and we will look for any inconsistencies, and we will be forgiven for thinking that all is well in this ankle. However, I hope that you would be able to detect that we have a fairly visible fracture here. And for those of you that may have not been able to detect the fracture, you can see that the fracture is highlighted here. In terms of body positioning, in podiatry we will often want perhaps a comparison between a weight-bearing and a non-weight-bearing view. In terms of this image, you can see that we have quite clearly a non-weight-bearing view. We can see this because we can see the plantar surfaces of the soft tissues appear curved, suggesting that they are not taking weight on a weight-bearing surface, and we can get an appreciation of this in terms of the architecture of the medial longitudinal arch. In this slide you can see the difference in the image that we ascertain, and this is from the same foot, in a weight-bearing view. And you can see that we get a different appreciation of the alignment of the structures when we go from a non-weight bearing to a weight bearing view. What we need to consider is very often some of the symptoms that a patient may present with will be related to weight bearing activities. So we need to consider whether a weight bearing view in some instances may be most appropriate, particularly when we're considering subluxations and problems with malalignment. So this slide summarises the most common projections that would be used to visualise the ankle. We have an anterior-posterior projection, a mortise and a lateral. In this slide, not only can we see the ultimate view that in terms of the image that we would ascertain, but this shows how the projection would be undertaken. And we can see the key difference between the AP and the mortise would be in the mortise view, we actually allow the foot to internally rotate to around 15 to 20 degrees. The process of this is that it actually opens up the joint, the syndesmosis, between the tibia and the fibula. In this slide, we can see an AP view of the ankle. We can see here the key structures that are highlighted. We can see that this particular view would be advantageous for viewing the ankle joint. What we would be expecting to see is the appreciation of the cartilage, which would appear as our joint space. And we should see that we would have a nice regular structure and flattening of the top of the talar dome and a nice regular boundary of the tibial plafond. Please bear in mind that when you look at a view of the ankle, very often it can be difficult to isolate the structures because some of the structures may be superimposed over the top of each other. In this slide, you will see that there are the varying key structures which are identified. Again, please take time to look at the varying YouTube videos which are supplied here in terms of getting a better understanding of relevant anatomy and how they would appear on an X-ray. In this slide, we can see a lateral projection of the ankle. So what we can see is that the ultrasound beam would have first hit the lateral malleolus, and we can see that this is superimposed over the top of the medial malleolus. You will see the image to the right shows the outline of the fibula, which is superimposed over the top and highlights the tibia, calcaneus and talus. It's important that you have some awareness of normal alignment because we will later, when we consider trauma, we will talk about some of the angular positions and how that may well make you more suspicious of a fracture or indeed a subluxation or dislocation. This is a slightly different positioning of the foot, but it's still a lateral projection of the ankle. And we can see that the foot has been allowed to plantarflex slightly more than in the previous view. In this slide, you will see to help you identify the key structures, various points have been highlighted for you. And again, please take time to access the web link and do some wider reading in this area. In this slide, we can see a mortise view of the ankle joint. And how would you be able to determine this? Well, it really is in terms of looking for the gap between the tibia and the fibula. And generally, this clear space should be 5 millimeters or less. For your convenience, you can see the area where you would look being identified by the blue arrow. In this slide, we can see the outlines of the tibia, the tibial plafond, the talar dome, and identifying the clear space that you would be able to identify between the tibia and the fibula with a mortise view. In this slide you can see a depiction of what would be considered to be standard views of the foot in an X-ray. This would consist of a dorsoplantar view taken from an anterior posterior projection and the oblique view. Please note that technically we would state that this is a view of the foot, and in order to do this we need to make sure that we have all of the bones visible as part of the foot. Please bear in mind that we may well have specific views of just regions of the foot, which may be restricted to simply the forefoot or midfoot. And it's important that you would have the precision in terms of your request when you would be sending a referral through. This is the same image as you've seen in the previous slide. However, what you will note is that for your convenience, the outline of the respective bones have been outlined. It's important that you begin to get the appreciation of how bones will appear superimposed over the top of others, as we have a 3D representation compacted to become a 2D image. Note how we will have a lack of space between the bones of the tarsus, so the cuneiforms. Note how you will see overlapping of the metatarsal bones. So please consider this when you're looking at an X-ray, and do not assume that these would be classed as fusion or lack of joint space within the bones. I would hope now that you will be able to recognise clearly that this is a standard view of the midfoot, because we are failing to see visualisation beyond the metatarsal phalangeal joints. Again, this would be a DP view of the midfoot from an anterior posterior projection of the midfoot. What you will see is, again, it appears that the metatarsals and the cuneiforms appear superimposed over the top of each other. You may wonder why it might be preferable only to get a view of a certain part of the foot and what the benefit of that type of projection may be. A standard view of the midfoot is particularly useful when there is suspicion of rupture of the Lisfranc's ligament. And in order to determine if this might be present, you would need to note the position of the second metatarsal relative to the intermediate cuneiform. Hopefully, in this image you will be able to see that there is a clear gap between the alignment of the second base of the second metatarsal relative to the intermediate cuneiform. This is indicative of damage to the Lisfranc ligament. This is the same image that you've just seen in the previous slide. However, we have highlighted some key structures. So what you will note is that we see this characteristic lateral displacement of the second metatarsal relative to the intermediate cuneiform. This is indicative of tearing or rupture of the Lisfranc ligament. In this image we can see a standard view of the forefoot. So you will see that we see a nice outline of the skin on the lesser digits, and you will see that we have a good appreciation of the metatarsal phalangeal joints and all the interphalangeal joints. This is the same image as you've seen in the previous slide. However, again we have highlighted the outline of the bony structures. You will see the outline of the metatarsals, the proximal phalanges, the intermediate or middle phalanges, and the distal phalanges. Please also note the sesamoids. In the practical sessions, I will ask to see if anyone has spotted any anatomical variants in this image. In this slide, we can see the typical setup for ascertaining a view. What we can see is we have our radiation source. We can see the direction of the X-ray beam. We can see the imaging receptor, which is the X-ray film, which in this case is under the weight-bearing foot. This is an example of an anterior-posterior projection taken in a weight-bearing position to give a dorsal plantar weight-bearing view. Here we can see the typical view in terms of an anterior-posterior projection, and I see that there's a mistake in this slide which will give you a dorsoplantar view. Here you can see the green area depicts where the centre point of the X-ray beam would be, and it gives you an appreciation of the alignment of the foot. Again, note the alignment of the second metatarsal over the intermediate cuneiform and the overlapping of the tarsus and metatarsals as the 3D structure is represented as a 2D image. In this slide we can see a typical example for a lateral oblique projection in a weight-bearing body position. Here we can see the X-ray source, the red arrow representing the direction of the X-ray beam, and that it would be directed in from the lateral side of the foot, but in an oblique direction. So this is the typical image of the foot that you would see from an oblique lateral projection. And what you will note is that we begin to see a much better outline of the cuboid and the lateral and intermediate cuneiform. We also see good visualization of the navicular relative to the talus. It allows us to see good visualization of the fifth metatarsal, particularly the base of the fifth metatarsal. So we have to consider when this particular type of projection would be indicative and what type of foot pathologies we may want to use this view to detect. In some instances, it may be appropriate to request a medial oblique projection. However, this is a much more rare projection requested. And one has to consider what the particular advantages of this projection would be. It may be indicative if you're wanting to have a specific view of the cuboid and navicular, as they can be clearly identified, but the cuneiforms will be superimposed on each other. In this slide, you can see the differences of how the foot would appear dependent on whether a medial or lateral oblique projection has been used. You can see quite clearly that there, in terms of visualization of more key structures, that the lateral oblique method, you are able to identify more clearly more structures of the foot, which explains why it's an approach and projection that's more commonly requested. This slide shows the typical setup in which to take a lateral projection weight bearing. What we can see in this instance is that we have the X-ray source directing the beam to hit the lateral side of the foot with the imaging receptor placed between both feet. In this slide you've seen this one before. However, just note in terms of with this medial projection, the lateral view, note that this is an ideal view in which to see the sinus tarsi. This image is the same projection, however, you can note the difference between the non-weight bearing and the weight bearing view. Now look at this image of the same projection. Would you say that this is a weight bearing or a non-weight bearing view? What clues would you use to determine this? This slide shows the arrangement that would be needed to undertake an axial calcaneal non-weight bearing view. You can see that the imaging receptor is placed under the calcaneus and the person is in a supine position. In this slide you can see the axial calcaneal non-weight bearing image, which would be achieved from the previous arrangement. Note that you get a really good view of the subtalar joint and the sustentaculum tali. This view can be particularly useful when looking for tarsal correlations. In this slide we can see an image of the axial calcaneal weight-bearing position, or more technically in this view it can be referred to a Harrison beef. In the Harrison beef position, the foot is flat to the supporting surface, which is the imaging receptor, but note that the ankle and knee are flexed, as if preparing for a standing jump. You must bear in mind that this particular projection in the view does tend to provide an elongated view of the foot, as you will see in the next image. In this you can see an image of a Harrison beef X-ray. This is similar to the axial calcaneal, except the patient will have bent the knee and flexed the ankle. You can see the apparent elongation of the structures in this view compared to the non-weight bearing axial calcaneal view. Please note again that you can see the sustentaculum tali and the sinus tarsi. In some instances, you may want to get a really good visualization of the sesamoids. In this image, you can see the setup for an axial sesamoid non-weight bearing view. Note the source above the foot, the direction of the X-ray beam, and the imaging receptor placed under the foot. The toes will be slightly flexed to allow better visualization of the sesamoid structures. In this slide we can see a typical image that would be achieved from the axial sesamoid non-weight bearing projection. How can we be sure that this is a non-weight bearing view? Well, we can clearly see that the soft tissue surfaces are convex in nature. If this is a weight-bearing view, we would identify that the soft tissues would adapt to the supporting surface and would appear flat. This view is particularly useful to look at the articular facets between the sesamoids and the plantar surface of the first metatarsal. You will note that you should see a visible joint space which would represent the cartilage. In this lecture, I've taken time to simply go through the most common projections and views that you're likely to come across, but please take time to look and access these YouTube videos where you will find more information around various projections. There will also be some instances where it's appropriate to stress certain structures in order to assess the integrity, particularly of some of the foot ligaments. In this unit, we wouldn't expect that that would be part of your knowledge that you would be assessed upon. However, it will be important in your working practice to have some awareness of the other views that could be useful in terms of determining underlying disease processes and pathologies. This slide shows a summary table of some of the common radiographic projections of the foot and ankle, which may be useful when you need to refer a patient for an X-ray. What you will need to do is think about the specific projections that would be the most appropriate to identify specific injuries or get the best visualization of specific structures. Please take time to do wider reading beyond what's been presented within this lecture to support your learning. It's important that you will have a good understanding of the various projections, resultant views, and what may be the best in terms of imaging specific structures or identification of key pathologies. In terms of a referral that you will need to make, you will need to be precise about what you actually want. Be aware of the standard projections and the most common views for the foot and the ankle. We will start to practice filling in some X-ray referrals within the practical sessions throughout this unit.